Так, ну, hello, dear colleagues, how are you? My name is Mynzhylky Berdikhojayev, and together with my colleague Shaykh Mohammed Khan. Shaykh, yes, this is Shaykh. We are from National Hospital of the Medical Center of the Presidential Affairs Administration of the Republic of Kazakhstan. It's a classical Soviet naming of the hospitals and organizations, but you can say that simple presidential hospital in Almaty. And now we have a patient number 1. She was previously treated. We treated her together with my teacher and my colleague Shimon Maimon in 2018, I think at the end of 18 and beginning of 19, or end of 17 or beginning of 18, I think. It was like this. 18'de bağlı, 17-18. Yes, December 17 and February, March 18. At the first session was done balloon assist coiling of the right MCA aneurysm. Small neck part is remaining, but it's not the question of the treatment for today. It was a more than 50% stenosis in this segment. And this aneurysm is new. At the time of treatment, it wasn't here, but it's appeared. Now I will ask Shaykh to give the shape for the ACOM, for the headway 17. The guiding catheter is 8 French Hyperion, which is coronary guiding. We're using regular sheaths and we're using irregular sheaths and which is short one, 8 French, and then coronary guiding, which is very useful. And then we took a scepter 415 and headway 17. Now I will ask for the Chikai Black and the Chikai Black perisons. Yes, Chikai Black. Қарасын бересіз ға? Chikai Black. Мына жасылдарды мынаның үстіне қойсаңызшы сосын. Сол жаққа қойсаңыз. И бір Praxis perisons. Yes, we will combine the headway 17 with Chikai Black, and then we'll combine the scepter C415 with the Traxis. For the MCA aneurysm, I hope it's enough to do balloon assist coiling. That's the first strategy. And for the ACOM aneurysm recanalization, we'll place I think Leo baby 2.5 by 25, and then Elvis Evo will be okay, I think. Okay, let's see which is better. Okay. Operating nurse is Zoya, and anesthesiology team Nazir K, anesthesiologist with the anesthesiology nurse. It's a specific of the anesthesiology system in Kazakhstan. We have physicians and nurses in anesthesiology. And all injections usually done by nurses, and doctor is doctor. It's prescribing and controlling most of the time and intubating. The rest is done by anesthesiology nurse. Okay, I think in post-Soviet countries it's typical, but in US and Israel, I think the doctor is doing injections and controlling everything. It's the specifics of the system. Okay, let's see the 3D. On 3D, yes, you can see the coiled part of the ACOM aneurysma. This is MCA aneurysm, new one. This is the previously coiled. Small remaining part, but it's not the question for today. There is some enlargement here in ICA, but it's part of follow-up. I think it's not a question of the treatment. Let's see these images. Yes, the small aneurysm on MCA. As patient had no rupture, as this segment is larger than regular, but we will follow. It's not true aneurysmal segment, just enlargement. And Sheikh Ahmed had problem in advancing the catheter up, and there is a recanalization of the ACOM aneurysm. It was not previously presented, and I think today we'll just place the flow diverter stent in this segment. And this aneurysm in follow-up, it's looked like a little bit changed. It was much more smaller, and now it looks like it's growing. Yes, I don't want dramatically decrease the flow in this aneurysm. Maybe we'll place one LV Evo to increase the FD possibilities. And for this segment, I think P48 should be okay, which is with HPC. That's this part. There is a contralateral A1, it's hypoplastic, but it should increase in size during the follow-up. Okay, Elvis Evo for MCA, P48 for ACOM, and coils for the MCA aneurysm. First of all, we will treat the MCA, then we will go for the ACOM, and at the end, if everything is okay, we will place the stent in MCA on the left side. As the other strategy to place the half T stent, then coiled aneurysm is also possible, but it could be tricky to go through the stent struts. That's why it's better to place the FD. Хайсу. Така остро жесаш? Қазір. Ауысатын кезде айтасың. Қоңырды ауыстыра бер. Все, қазір жабам, ауыстырасың. Все ауыстыра бер. И қоңырды шешіп, қайтадан қоссаң. Хорошо, сәл ұзақтау жұмыс істейміз, поэтому артығымен тұра берсін. As the coiling catheter will place here. Бізде headway 21 жоқ, да? Ана гамманың ішінде, по-моему, ребар 18 бар. Сон бері шығарасаш. Ішіндегісін көрсетесаш, не бар екен? Осыны айтқан кезде ашасың. Пока ашпай тұра тұр. Сосын мына стентерді бері шығарасаш. 3,5-17. 3,5-17. Так, и P48 деген бар. Соны ашсың. Ашпай тұра тұр. Оны айтам. Пока нетпей тұра тұр. Окей. Оларды пока қойып қоясың, ашпай тұра тұр. 2,8 деген бір спираль бере сал бізге. Yes, and I'm asking for the first coil 2/8. Usually it's Optima. Дайындап қоясыңыз. Yes, it's also possible to place the stand. Optima наш сол. It's also possible to place the everything is possible. Let's see. This is Traxxas. The segment is not so complicated. That's why I hope Traxxas will go. And before the inflating in intracranial, I will check the balloon in extracranial circulation. Usually I'm not doing it, but today I will show you how to check. Sheikh Ahmed already prepared the septer, and now we will take second microcatheter. Okay. Let's take out these shields. I start to do it because of the Alberto, my friend, said me it's increasing the radiation level. Yes, he's correct. It might increase the radiation, but if there is air, then it's possible to decrease the air. To increase the visibility if there is some air around. Okay. The angulation is left 5 and caudal 25. We'll do the maximum zooming. Yes, the treatment was more than 7 years ago, and new aneurysm formation is possible in 10% of the cases in patients with the multiple aneurysms. It's expected. Бар ма екен? Онда ХДВ-20 бір ашсаңыз. Ребарда болады? Ребар болады, жаңағы ребарды ашсаңыз. Пока ашпай тұра тұр. Айтқан кезде ашасың. Yes, those aneurysm is also a little bit with recanalization, but I think we shouldn't place stent today. That's why we will plan this small recanalization for the next time. 3 stents will be too much. Even 2 stents is a little bit more. I hope to just simple coil the right side and place the stent on the left MCA and flow divert to stent in ACOM. Yes, and the next time we can do stent assist coiling for this recanalization in MCA territory. Yes, even yes, it should be stent assist coiling. And it's better to finish like a half T to avoid to expand the stent in stenotic segment. But it's not so much stenotic, huh? Jens Olsen, okay. It's not so much stenotic, but it's stenotic. It's nearly 30 to 40%. I will try to avoid this stenting. Okay. Let's place balloon first. Maybe. But it was look like stenosis last time in 2017, and it's not increasing. It's a good sign. Not increase. Okay. Then it could be a little bit problematic to go to the side branch. Okay. Let's take the balloon forward. Yes, we can place it like this, and aneurysm with small neck should be okay. Okay, let's place it here. But first of all, I need to check my balloon. I will try to inflate it in the ICA. ICA is bigger, and it's visible. The balloon is visible, it's good. Yes, to check the balloon usually is better to pull it to the more bigger anatomy. Yes, on lateral we can control the position of the balloon. Okay. Okay, now balloon is past the bifurcation segment. It's mostly for the security than for the remodeling. The neck of the aneurysm look like not so big. Some friction. If you want to go to this branch in the regular life, it's impossible, huh? But now it's going only to this branch. I don't know why there is a lot of friction now. And it's so-called shipping technique. When you place one device, the second device is automatically following. Yes, maybe we can ship the scepter also. It might be better. Такое ощущение, что пациентка кашляет или движется. Пациент жөтеліп жатқан жоқ па? Yes, it's better to... It's better to replace the balloon, and the microcatheter now is shipping. And that's why it's not so comfortable. I will replace the balloon to this branch. It's better to replace it. It's so-called shipping technique. Thanks to Professor René Chapeau, we learned how to do this, and it's So elegant, huh? Как будто пациент кашляет.
Дергается, что ли?
Нужно было напишать. Подергивается. Такое ощущение, что подергивается. Yes, it's looked like this straight access, but the small aneurysms are usually challenging. Eh? Дергается, не знаю почему. Наркоз теремка, да? Назырки? Смотри мозг.
Yeah.
Назад. Бред назад. Угу. Стоп, терем. Ага, смотри мозг. Okay, now it's not like we're inside the aneurysm. It's too small. It was look like it's stuck at the orifice of the aneurysm. Okay, now we are in the branch. Yes. It's look like now microcatheter is inside. Yes, we are inside. It's too small, and because of the anatomy, the movement is not one by one. Интересно. Зоя? Сквиттер көрсетесіз? Екі менік шекерге қоясыз на всякий случай. Айналып тұра берсін. Yes, the first coil will be okay, let's check how it's look like. Now the coil is arriving, and as the guiding, it's look like position is okay. Okay, coil now right. It's maximum. I will increase the radiation. And now предыдущий ангел. Стоп. Smart mask. Okay, let's start to coil. As if you see the shape of accordion, then there is a pressure on the wall. It could be the pressure on the wall of aneurysm, and it's better to little bit pull the micro. And now we will inflate the balloon just for the security. To keep the microcatheter inside the aneurysm. Maybe one coil is enough. It looks like one coil might be enough. Okay, let's deflate the balloon. As the microcatheter is outside, and the first top of the coil is also outside. Yes, everything is outside. Just a second. Let's see, maybe we need a second coil. As it was looked like the small neck aneurysm, but finally the neck looked like a little bit wider than we expected. Zoe, sürüyor koyuyorsunuz. Okay. The first coil is inside, and on the lateral it looks like we can place second coil. Нет, бересал. Отделок. Отделок. Okay. Высыл. Между аксиом державника бересешь. Ашер. I hope the 1.5 by 2 coil will fit well. Let's see, if the coils start bulging, then we can place Leo baby stand in this branch, no problem. We have a double lumen balloon, and we prepared to place the stand, no problem. Just a second. Так, бізде интракрanial стенттер қамай қойып тұр, для стенозов мынаны алып тастайсың. Ана жақта коронарный стенттердің жағына қоясың. Бұл коронарный стент. Хорошо. Okay. Oops. Okay. We ask for second coil. Second coil is axiom, axiom helical, 1.5 by 2. It's a regular axiom, it's not prime. That's why it should behave as we used to use this kind of coils. Yes, it's thick. The aneurysm, just mechanical detachment like this. And now, as the last loop of the coil is outside, we just need to push it. Oh, it's okay. Let's take out the headway. Okay, let's wait nearly a minute. Tiny. Usually the coil will take place and will help to stabilize with the blood and with some fibrin inside. Okay. For the ACOM, I prefer to place the flow diverter stand because it's a recanalization, and the ACOM is also taking the circulation of the right side, and it's possible to bulge with catheter to the right side, and there is a pericallosal artery also. Okay, it's 43 seconds, and now we'll deflate the septor. It's stable. Okay, it's good. Yes, it's nicely coiled, and it will be occluded. It's okay. It's small aneurysm. Usually it should be okay. For the previous MCA aneurysm, it's necessary to place a stent and a couple of coils. Now we are planning to place another 2 stents. That's why the stent number 3 will be extra. And if it would be some problem with the gastric system, then we should disconnect the antiplatelets. It may lead to some kind of complication. Ребарон се издаш 50 Қолмен. Так, мынаны ребар қоссам. Ребарды 45 градусқа бұру керек. Аша бер. Okay. We need to take out this slowly. Yeah, дұрыс. It will take time. Yeah. But not first. A second. Басын 45 градус қыласың. Фен. Yes, aneurysm is occluded. Yes, this aneurysm is occluded. We have ACOM aneurysm. Okay, let's go to the left side, and then we can decide about the FD finally. Maybe stent could be also possible, but we will see. We will see. It's subclavian. I need a wire. Так, G-проводник тоже пояснишь?
G-проводник.
Норма? G-проводник. I'm asking for the G wire. To the navigate. Делёсный мı? Делёсный мı? Суперстив var mı? Суперстив деген var mı? Boston. Extracranial circulation. Жоқ, қажеті жоқ. Шайхмет. Вроде жүріп отыр, қажеті жоқ. Тағы да біреу керек. Кастратор. Unicol, надо Unicol. Екеуі де Unicol. Okay, let's place the balloon in maxillary artery and then we can inflate it. It's so-called anchoring. It's arch bovine, that's why it's a problem. Huh? Okay.
Едем
Обычный G-проводник. Yes, in arch bovine usually it's a problem. Yes, where in extracranial circulation, maybe we'll take a 125 microcatheter, catheter, which is diagnostic one. Var mı ekan? Так. As for this reason, it's better to take Neuromax, but okay, на наш персонаж. We'll take a 125 centimeter diagnostic catheter for the support. I hope it will give us support. Так, per second. Let's take the balloon. Let's take the wire. Now we will need to flush the castrator. Тікелей olsun. Интервенция. Қазір жоқ деп сөйлейтін болған екен ғой, да? Өте ограниченный портфолио кішкентай көп нәрсені жасай қоймайды. Жүзи ханым, қалайсыз? Ладно, жарайды. It's not giving the support. Maybe we need to talk a little bit and then push. Yes, now it's going. It's going up. Then we need to redirect to the MCA. Yes. So choose it here. Thank you. I will try to place it as distal as possible. Так, на стол алсам. Ішіндегісімен тұра берсін. Okay, now we will do epilateral. Then I will ask Sheikh Ahmed to do 3D angiography, 3D and expert CT before placing the stent. Let's check the possible changes after the coiling of the first aneurysm. Okay. What's this slow flow? Вперед, вперед, вперед. Назад, назад, назад. Ага, вперед. Вперед, вперед. 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 It looks like it's a flow diversion effect of the yes, because of the stent, it looks like there is a slow flow. Okay, let's take a nimodipine. Вперед. 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 Yes, the stent is in place. The guiding is in place. There is slight slow flow. 5000 гепарин салсаңыздаршы. Okay, let's check how it was at the beginning. Maybe because of the slight spasm. Zero. It wasn't before, but after placing this catheter, it's a little bit stagnating. Okay, I think the placing the stent in MCA may increase these changes. Промывка нематоп қоссаңыздаршы. Зоя. Ана қоңырға нематоп 8 қосты, и біз қайтан переключимся. Yes, it's a little bit increased. Stagnation. Okay. Okay, now it will be better. Yes, because of the spasm, there is a retrograde flow. Okay. Тез тез немотоп бересиш. Бізге 20-ка 2 кубик аласайықшы. Ана, пока қоса бер. Okay, now I took Austrian. I took 2 cc of nimodipine. Aynı alacağız. Yes, nimodipine. 2 cc. And now we will inject the 5 cc from 20. It was diluted till 20 cc. And I'm asking Shahmed to do 3D angiography. Осы кітап күшті кітап дейді. Кім оқып жатқан? Is that? Okay. We made a 3D angiography and CT. CT was with some stagnation in this territory, and I checked this branch. This branch is coming outside of the aneurysmal branch. That's why maybe it was a small emboli in that territory. And now we can see this is the neck of the aneurysm. Maybe it's possible to place several coils and instead of placing the FD, maybe, or just simple FD will be enough with this projection. Let's see how it would be. If it would be easier to navigate rebar 18, then it's okay. Okay, now Shahmet made a там есть вот этот экран, review он называется, который справа третий, по-моему. Вот этот, наверное, да? Нет, не он. Okay, it was look like some emboli in this territory. Maybe the thrombus will resolve. It's a retrograde flow. I don't want to take a risk to go to this distal territory. Yes, here it was, but now it became slower. I don't know why it stopped. Okay, let's see. Enlarged. It was this branch. And now... А можете обычный экран поставить? As this branch is going. And here something happened to this territory. Okay. This territory is at the coronal suture. I don't want to go there. Maybe small thrombus is went. You see? Maybe small thrombus during the navigation. Okay, let's see. Let's check. This was the last angio. Not last, it was the 18th series. And it was something went from here maybe. Okay. Okay, it's a big territory, eh? This branch territory. Okay. Yes, let's see it here. I'll decrease it to normal to check. Yes, this branch is in place, and there is another branch coming here, and it's filling retrogradely. Okay, like this, and now we'll take image number 18. Yeah. 17 and 18. Let's zoom it a little bit. That's one branch, and another one is going like this, and second is going like this. And here one is coming like this from the collaterals, and the second is coming from here. At this point, small something is left, but I hope it will resolve till the end of the cases. I don't want to go to this M4 territory. for the distal thrombectomy, I think it's not necessary. Okay. Rebar 18 is ready. Now we will take a Chikai Black. Okay, it's also possible to navigate the right 31, 22 caudal. Yes, it might be better to navigate the Silk Vista baby. Right 31. And 22 caudal. Yes. Okay. I hope the navigation will be smoothly. Yes, the problem is we have no integrally no real pro. Tirofiban, yes, it's also not available. Yes, this tortuosity will limit the navigation of the microcatheter. Одну секунду. I think the lateral we don't need so much enlargement. I put a little bit more nimodipine. Yes, there is a small segment in the branch, but we have retrograde filling of this segment. Smoke mask. The smoke mask is in place. Yes, usually to give a more mobility and to take the catheter back. Then we can push the wire. Yes, now it's better. Гепарин ставим?
Гепарин весь не столу, да?
Гепарин, Now the Chikai Black empirical vessel artery is 304 segment, A3, A4. Okay. The question number second, how it would be pushable, the T48, huh? Okay. There are two options. Вперед, дальше. The option number one, we can place the small microcatheter in the branch and we can inject Alteplase to this branch. That's option number one. And option number two, do nothing because of the distal collaterals. And I think the broca is more anterior, yeah? Okay. I'm talking about this branch. The motor cortex is here. This is pre-motor area, but it's feeding by collaterals. Only this segment is occluded. Only this segment is occluded. Broca is something here, eh? Okay. Let's do nothing for this small branch. Не наберешь? Зоя, P48. Yes, we will place P48 HPC, which is a flow diverter stent with hydrophilic coating. Yes, this is for stability. It's a very thick, да? Тонкий. Thin, yes. Все, сейчас подожди, сукельсон. Okay, let's wait for the water. Here. Let's wait for the water. Коробкасын тағы бір көрсетші. Шейхник былай тұра тұр. Камерадан көрсетші. Yes, it's 3 by 18. It may start from 2 mm till 3 mm, and it's elongating till 25, and it's delivering by 21 microcatheter. Okay. Все, трас. 5 секунд. Все, интерьер. Все, вперед. До конца интерьер. Я был. Yes, I'm not sure should we take it out because it's a second version. Let's see. Because the P64 second version, you don't need to touch the hub. Okay, I think we need to take it out. Just a second, Tratro. Jerusalem. It's doing like this. It's not so comfortable, but it's okay. There's so many tortuosity in proximal. That's why it's a little bit. The pusher wire is a little bit damaged. Yeah? Okay. Contrast. Yes, it starts to open well. And, okay. I'll release it fully. Yes, now it's re-navigated inside. That's good. Patient under prepared holiday. Okay, patient on Berlinter. And yes, the proximal minus pressure. The proximal part is nicely visible. Okay, maybe we need to place the balloon and we'll do the angioplasty, but it looks like it's well opposed without any issue. Okay, balloon is arriving. Yes, we will use the balloon to place the Leo baby stent in MCA. Yes, now it's distal. I will pull the septor a little bit. Then it's navigating inside the stent. Now it's good. Okay. Let's inflate the stent here. But after this manipulation, I think the stent is fully opposed. Okay, it's just angioplasty for the P48. Yes, stent is fully opposed. I just need to go back. Okay, let's see. Yes, the flow will be changed because of the flow diverter. It's not the braided stent, it's flow diverter, and the aneurysm will shrink and disappear. It works. And for the MCA, I think we need to put LVC1. Okay. LVC1 or little baby. The aneurysm is start to has a diverticulum. Okay. I will take out my rebar now. Yes. Sunç Johnson. Capins Johnson. Capins Johnson. Yes, the territory is took by the distal collaterals on the MCA, and for this aneurysm, just a second. Okay. For this aneurysm, the stent is well opened and well opposed. Yes, and it's with HPC coating. Новый Хасл. Yes, there is distal collaterals, that's why it's not so big problem. Okay. Now we will take AP and lateral. Yes, and for the M1 segment, there is a question. It's also possible to place little baby. That's option number 1. And option number 2 is place the placing placing the braided stent. LVCO or little baby. Yes, P48, it's okay. Okay, let's measure the MCA, then we can decide. I don't want to go there. Web device might be an option, but it's again the problem with the navigation inside the stent. It looks like 20, 16, 2.4, and distance from here till here 16 millimeters. 16.4. Yes, in a case like this, maybe little baby is better. Okay, let's see. we have enough time. We need to wait also for the P64. It's a Kazakh thrombosis, but with Triventin, ticagrelor, everything is okay. Yeah? Так. Evan көрсетесіз. И мына Leo Baby біреуін алсаш, 2,5 жыл ойыз. Ал бер. Сыртын көрсетшіш. Все хорошо. Yes, we have two options. Evo 3,5 17 and Leo Baby 2,5 25. I prefer Leo Baby. Yeah. Okay, 2,5 25. Telescopic Leo Baby works like a flow diverter stent. Telescopic is the meaning of placing minimum 2 stents. It's automatic. We are looking for this, but automatically I'm just pushing the wire. Okay. Let's renavigate. Okay. Smart mask. 1 time, 2 time. In case of necessary action, I prefer to place it in the second branch, but it's not going. So only here. Okay. Let's place the stent before the bifurcation. Согласен. It's more than 7 minutes for the ACOM segment. Just a second. Just yes, the stent is okay. Was it? Mynzhylky? Yes, stent is okay. Все интересно. Now we'll push the Leo Baby. The first baby was 2.5 by 18, I think. And now we have 25, and we will end the same end and a little bit proximal. think I need to push a little bit forward. It's too much in the M1. Okay, then we will cover the segment. That's okay now. Yes. Okay. Now it's better. Yes, now the branches start. It's a good sign. You can see the contrast is now start to stop a little bit in the aneurysm, and it's a good sign. It's a flow diversion effect. The next treatment will be in 6 months, and I hope we can control that everything is okay. 6 months. Okay, from this point I prefer to wait так, 20 шприц. Таймер қайтадан қоясың. Let's do hijama. And from this point of treatment, I prefer to wait another 15 minutes. Another 13 minutes, okay? Шехмет. Okay? Подместный. Келесі 2% подместный. Я тоже подместный. Там перикардит по. Yes, after this case we have a IC aneurysm. The patient is 80-something years old and with some comorbidities, but it's IC aneurysm, it's okay. And patient number 3 after pericarditis, patient number 3 after pericarditis, and I prefer to treat him with the atrial fibrillation with the local anesthesia. Yes, the territory is covering by the collaterals. That's why I prefer to not to touch that segment. As the AC collateral is coming and covering the distal part territory. That should be okay. Let's do control angio first, Shahmed. And after control angio, let's do control CT. And on minute 15, let's do minute 13, let's do control angio. And then we can finish. If everything will be okay, Shahmed will show like this, okay? Let's see the persistent trigeminal artery, the territory. SPCA territory is correct. No, that's okay. It's clear. Okay. the small thrombus in MCA territory, but I prefer to do nothing because at that territory we can perforate everything and will cause hemiplegia and aphasia. With the distal collaterals from the ACA territory, it should be asymptomatic. Okay. Okay. Let's wait till minutes 13 before Sheikh Ahmed will do control CT and will show you everything is okay, and then on minute 13, in 10 minutes, he will do last CT, DSA and we can finish. Thank you. I will disconnect my voice and video will continue for 10 minutes. Thank you. See you in 25 minutes.